Hello and happy Teach Me Tuesday on a Thursday. My name is Lisa Houston and I am a NICU nurse educator specializing in NICU education for new and experienced nurses. Usually we do our Teach Me Tuesdays on Tuesdays, which we did, which was cardiac medication used in the NICU, part 1. And today on Thursday, we are covering part 2. So you haven't watched part 1, go back and watch it. It has the Let's Review area and it has the patient education, the parent education, which we will not go over today. But I did want to also point out that these can be watched independently, but that has a lot of blood pressure medications, what to do if your baby is hypotensive, and today we're going to talk about more specialized cardiac medications. First, we're going to start with PGE1 or prostaglandins, alprostadil, however you call it. So PGE1 is primarily used to keep the ductus arteriosus open, especially in the setting of a congenital heart anomaly. Spoiler alert, during this month of February 2025, Heart Month, Heart Awareness Month, we are going to be going over some congenital anomalies. So knowing about PGE1 will help you for some future learning together. But what PGE1 does is it maintains ductal patency by relaxing the smooth muscle and the ductus arteriosus. And how I always describe this when I'm teaching this in a classroom is with the ductus arteriosus, it's meant to be open in utero because the majority of the blood bypasses the lungs and goes out to the body because it's already oxygenated from the mom, aka the placenta, aka the greatest temporary organ to ever exist. Throwback if you've been watching for a while. After birth, we want the sides of the ductus arteriosus to come closer together until it closes. What PGE1 does is it says, hey, you guys just relax over there. We're going to keep you calm. We don't need you close together. We want this nice and open so that blood can continue to flow through there. This is given as a continuous IV infusion, anywhere from 0.01 to 0.1. Again, these are standard NICU doses. If you work in a cardiac ICU, you may see different doses. This is primarily used in ductal dependent congenital heart anomalies, such as coarctation of the aorta, transposition of the great vessels, tetralogy of Fallot, lots of them, truncus arteriosus, right? Lots that we're going to be going over. So we also have some changes in our contractility and our heart rate. We will see some vasodilation. That's this idea, right? It's a smooth muscle relaxer. We want everything to vasodilate. We just want this nice, calm ductus arteriosus. So that's PG1 prostaglandins. Its opposer, right? If you had an antonym for PGE1, it would be ibuprofen. Ibuprofen, indomethacin, and Tylenol or acetaminophen all kind of do the same thing. They are trying to close the PDA. Ibuprofen, I did some little evidence-based research before I recorded this, and it now is the most commonly used medication in the NICU for closure of the PDA. So something to keep in mind there. What it does is it inhibits prostaglandin synthesis. So it's saying prostaglandin, don't come over here. You're not allowed because we need to come together. So instead of being loosey-goosey, it's causing this constriction and closure of your ductus arteriosus. Ibuprofen is usually given kind of in a burst, followed by 2 maintenance doses. They are IV intermittent medications. This is not a continuous IV medication, so keep that in mind. So that's primarily what we use ibuprofen for, especially in relation to cardiac medications. I have not seen it for anything else specifically. So we use this intermittent medication to close up that PDA. There are contraindications to ibuprofen, so make sure you're looking into that. We have some, if a baby's had neck, we have if the baby has severe IVH, so make sure you are double checking those things and your line compatibilities like I preach with everything else. So let's talk about some medications we would give if your baby had an SVT. So those first two meds were kind of about your PDA. Now we'll talk about if you have SVT going on, supraventricular tachycardia. So as NICU nurses, what we really need to learn and talk about is, hey, what are these doses that we're going to be giving and how would we best help these babies? So adenosine is kind of our first line of defense for this SVT. It's given as a push. Maybe you've done some other interventions such as ice to the face. or whatever you might be doing on your unit to help out the baby. But this is going to temporarily block that AV node conduction and restore normal sinus rhythm. So that's adenosine. We can also give propranolol, especially for kind of ongoing maintenance of SVT to help bring it down. We do use propranolol in other instances in the NICU, as you may know, for hemangiomas, but specifically for heart, this is what we're talking about. It's a non-selective beta blocker. It decreases the heart rate. Propranolol, we also have to watch their blood pressure when we're giving propranolol, so keep that in mind. But this can decrease your myocardial load, and just going to give those doses intermittently. So that's why I would give propranolol as kind of our ongoing maintenance for these babies that have chronic SVT. If you have SVT that kind of isn't going away, right? This is something I've seen is esmolol. I have probably given this medication only 3 times, and that was in the last 6 years. So this is not a medication I'm as familiar with as others. It is a short-acting beta-1 blocker, primarily used for arrhythmias, SVT. That's who I've seen it on in the NICU setting, and to use esmolol for that. So when we think about those common arrhythmias, right? SVT is probably what we're going to see most commonly in a NICU, especially if you're in a level 3, maybe a level 4 that doesn't have ECMO or cardiac ICU. Kind of when we get beyond that and we get to a place where we're baby's kind of constantly going into some alternative waveform, some alternative arrhythmia, their heart rhythm just isn't normal, they're probably going to get transferred to an outlying hospital if it can't be managed, or if you don't have a cardiac doctor on 24/7. So this may not be a medication you're seeing often, but I wanted to make sure you had heard of it and kind of known it was around. Milrinone also kind of falls into that category for me. I had not used milrinone often. This was a new to Lisa medication in the last 6 years. It improves contractility and vasodilation. I've primarily seen this used for pulmonary hypertension in conjunction with I&O. I have not seen it used by itself. Obviously, if the baby's weaning on those 2 things, you might have a period of time where they're off of that. That's been my experience. I've also read in 2 places about this max dose. I never saw a baby on that much, so I personally never saw that max dose, but I wanted to make sure that we mention that because it's important that we're aware, especially for these intermittent medications that maybe we're not using as often as we could. I've worked in 3 NICUs, right? One of them, our unit was about 45 beds. Our average daily census was between 30, 35. One unit was kind of spread over 3 floors, and it had anywhere from 75 to 100 babies. And then one was a giant unit where it had average daily census of 88, and we had babies there up to a year of life. So we saw a lot of different medications in there. All those experiences have taught me that we are going to continually learn about new medications. Eventually, medications that we use on adults are going to trickle down to babies. That there are medications like milrinone that are improving the contractility. They're improving the vasodilation. When we think about pulmonary hypertension, we really think about this idea of that constriction, which we're going to look at on our next slide. But really, if we can help fix that, we're going to help the baby improve. So usually in conjunction with I&O, which does that as well. We talk about I&O more in our respiratory lectures, so if you want to go back and learn about that, or we could do it as another topic in the future if you want. But let's talk about another pulmonary hypertension medication, which is sildenafil. The interesting thing about pulmonary hypertension is this is a cardiac pulmonary disease together, and that's often why we talk about it with pulmonary, but what this is doing is improving vasodilation. In general, we all know what sildenafil is, right? So vasodilation is what's going on here. We give it typically intermittently, IV doses. It can also be given PO. It can be a long-term medication that a baby is on as they're weaning off of I&O. That's one thing to really consider is kind of where would I be seeing this. I've seen sildenafil used in older babies that are kind of trach dependent and have kind of persistent pulmonary hypertension where maybe they're not in a crisis, but it's not coming down. So that I've also seen it used there. And we also obviously see a lot of pulmonary hypertension on our babies with congenital diaphragmatic hernias, and then the BPD, bronchopulmonary dysplasia. That's what I'm talking about, kind of those chronic trait kids. So this is going to improve your oxygenation, right? If you can see in this picture, pause me, right? Zoom in. Look at this idea of what pulmonary hypertension is. It's a constriction and a backup in the vessels that are allowing the exchange of gases. So if we can vasodilate them and open them up to allow more blood to be moving through, the baby is going to improve. In this recap slide, I'm not going to go through everyone. This is everything we have talked about during cardiac medications part 1 and cardiac medications part 2. So I kind of just wanted one summary table where you can kind of see what it is and see what's going on, see all the different things here, see the medications it's used for, see kind of how we sorted it together in doing our blood pressure medications together, things that we're using for our Duchess arteriosus, what we're using for SVT, and then our pulmonary hypertension medications. Again, this is 2, 4, 6, 8, 10, 12 medications that we're going through in our cardiac med lecture. There are other medications out there. We will not be able to cover all of them in one post. There are going to be other medications that you're exposed to. So this is when you're going to use your resources. You're going to call your pharmacy. You're going to talk to your provider. You're going to see what the echo says so that you can compare that echo and say, oh yeah, that left ventricle wasn't pumping right. That's why they switched to epinephrine. Or the baby was on esmolol and now we need to get to this place of maybe getting them off of there. How could we get them off esmolol? Maybe that's when we're going to go down to propranolol. Or they were on milrinone in conjunction with INO. Now we could try some sildenafil and get them off of that as well. So kind of putting those pieces together of what are we treating, what have we used, and where are we now in conjunction with kind of the baby's whole story. So to recap kind of our whole cardiac meds part 1 and now cardiac meds part 2 is that cardiac meds play a key role in the NICU with heart-related conditions. So even thinking about all the units I've worked on in those level 2s, those level 3s, a level 2, maybe you have an unexpected congenital anomaly and you've got to start PGE while you're waiting for your transport team, right? This is a great review for you as well to kind of know what you're doing with that. These medications can have a significant effect. We need to be watching their heart rates, their blood pressure, their urine output, their oxygen levels, all of that to make sure that they are getting the right doses. We need to empower our parents to answer questions, to participate in neurodevelopmentally appropriate care. These babies also, especially babies with pulmonary hypertension, we do often have to sedate them in a way so that their heart and lungs can work together. But positioning devices, having parents do touch hold, having parents be present in the room is going to increase their bonding and help that baby long term. When we first put hands on, it might be tricky for the baby, but over time they are going to do better in the presence of their parents. So we want to help confidently transition these babies home. We want to set them up for success. So knowing the mechanism of actions, the common dose, and what we're treating is going to help you be a successful NICU nurse. Thanks for joining me this week. Stay tuned for next week when we do another week of cardiac during February Heart Month.